available was less. And thirdly, because of the availability of instruments, because pediatric population as such needed a separate instruments of smaller size and smaller diameter. So presently, minimal invasive surgery is considered for evaluation and management of many pediatric tumors. Now we will deal with the present consensus of use of minimally invasive surgery. So it has become the standard treatment approach for many operations within all age groups in pediatric surgery. But when we consider pediatric oncology as such, it has not yet been implemented within any guidelines or recommendations in most of the current treatment protocols. But isolated case reports and case series are there which support the use of minimally invasive surgery in pediatric oncology. Now, with differing role of surgery in different entities, because pediatric tumors, most of them have heterogeneous type of presentation. So it is not a universal type of presentation. So it is not possible to attribute a common objective to a single surgical approach such as minimally invasive surgery. Because in some tumors, a complete resection is required, but in other tumors, a complete resection may not be required. So in that entity, the role of minimally invasive surgery changes. So depending upon the type and the heterogeneity of the tumors, the objective also changes. Objective of the surgery also changes. I'll come into the details of individual tumors later on. So, but most important thing which we should keep in mind that it is not the short-term outcomes or the short-term benefits which we should consider or we give more importance. Rather than that, we should adhere to the oncological principles, and it should be given more important than thinking that whether minimally invasive surgery is feasible in such a a particular child or not. So the importance has to be given to the long-term outcomes and adherence to the oncological principles rather than cosmesis and immediate short-term benefits. Presently, when you consider the present usage of minimally invasive surgery, presently it is used as a diagnostic modality and for staging and also for therapeutic uses. Therapeutic uses in turn means for resection of the tumors, and other uses will also include second look surgeries after chemotherapy or after a primary procedure, and also additional procedures. Additional procedures, for example, in case of pediatric lymphomas, which requires bifield radiotherapy or the pelvic nodal irradiation, we need to protect the ovaries in case of females. So in that case, we'll have to do a oophoropexy. So in this can be done easily with a minimally invasive surgery rather than going for a larger incision and an open procedure. You can easily do it with a minimally invasive approach. So that is the use of minimally invasive surgery as in additional procedures. Now coming to the impact of minimally invasive surgery on tumor biology. So it is a proven fact that it has got an impact on the immune system. So the basic idea behind this thing is that when we use minimally invasive surgery, the inflammatory cascade stimulation or the activation of inflammatory cascade will be kept to the minimum. There will be minimum amount of stress to the body when compared to open surgery. And also there are some physical properties of the gas which is used to create the pneumoperitoneum or pneumothorax, and that has also got some role in affecting the tumor biology. Because some studies were also done, mainly animal studies, they were done which showed similar effects in studies comparing both CO2 insufflation and air insufflation. So there is no obvious harm in inflating with CO2 in case of laparoscopic surgery. So it won't add on to tumor spread or progression when compared to open surgery or compared to air insufflation. Now, the effects of gas, when we talk about the effects of the gas which we use for creating pneumoperitoneum, there is always a localized acidification. So, pneumoperitoneum-based surgery results in reduced levels of circulatory cytokines and a better preserved cell-mediated immunity in patients. In a nutshell, it means that inflammatory cascade will be, stimulation will be kept to the minimum. And there is some controversy which exists about the role of direct and indirect effects of CO2 in patients with malignant disease. But some studies are showing that overall outcome is remaining the same. And some studies are also showing that the tumor progression can be also reduced, because in some animal studies with neuroblastoma, when scientists did just only insufflation with CO2 and they compared it with the insufflation of air without resecting the tumor in animal studies, the tumor progression has slightly decreased. No proper RCTs are there to comment regarding the same in humans. This is again the same. randomized trials on colon cancer resected by laparoscopy and also versus conventional surgery have also shown similar recurrence rate and overall survival. Now coming to the major concerns regarding the use of minimally invasive surgery. When you're talking about the concerns, first we will discuss about the short-term benefits and then we will discuss regarding the long-term outcomes and also the concerns. The short-term benefits mainly includes, as we all know, for a minimally invasive surgery, there will be a smaller incision, less post-operative pain, early recovery, and shorter stay in hospital. Especially in case of pediatric oncology, it is important because if the patient recovers fast, that early we can start the chemotherapy. Now coming to the long-term outcome and also the concerns and some intraoperative concerns. One is the completeness of the resection. But in laparoscopy, there is always it is always a doubtful part regarding the completeness of the or the ability to complete the resection or to get an R0 resection. Then most important thing is there is absence of tactile feedback. So localization of deep-seated tumors and it will be difficult. And also there will be less working space because it is pediatric population. The localization or the tactile feedback is important when you are doing wedge resection of surface lesions or the metastatic lesions, because in lung and all, if metastatic lesions are not present on the surface, but if it is clearly seen in image, then once you go in, you won't see any lesion on the surface, so you cannot do a wedge resection. So some type of localization or image guided localization has to be added to it to enhance the resection completely. So that is one drawback. And the other thing is risk of tumor spread, especially when you are retrieving the specimen without, if you are trying to retrieve the specimen without endo bag, there is always chance for tumor spread. This tumor spread or when there is tumor rupture, this is always important. It is an important prognostic factor, especially in tumors like Wilms tumor. Another issue is port site recurrences, but port site recurrences as such, the case reports or the evidence regarding the port site recurrences following minimally invasive surgery is rare or very less. So that is not much of a major issue. Then regarding tissue retrieval, as I said, if there is tumor spillage, there is always chance for tumor spread. So always an endo bag has to be used for tumor retrieval, and morcellation of the specimen has to be avoided because there is always chance for rupture of the tumor bag if you are trying to crush the specimen, and in turn it can spread and can cause tumor spread. And another issue is heterogeneity of the tumor, as I had discussed earlier. Now coming to the uses of minimally invasive surgery, I will just give a brief introduction regarding the different uses, and then we will come to the specific tumors as such. Now, first of all, diagnostic. So, as a diagnostic tool, it always comes secondary to percutaneous image-guided attempts. So, only if the percutaneous image-guided attempts fail, or if the tumor is in a particular location which is not accessible percutaneously, then comes the role of minimally invasive surgery. So, always there is a conversion rate chance, but it is less than 5%. But the thing is that the diagnostic accuracy of minimally invasive surgery as a diagnostic tool is almost up to 100%. It is always better than percutaneous image guided biopsies. But since it is a non-invasive procedure which requires which doesn't require general anesthesia, always percutaneous image guided attempts has to be made first. If it fails, then go ahead with the minimally invasive procedures which requires anesthesia. And port site recurrences are also rare. Various studies are there by Ivanenka and others, but all these data lack long-term follow-up. Now, another use is for tumor resection or for therapeutic purposes. So, tumor resection as such, you will have to include the patients in the group after thorough assessment, because you need to select your patients. Otherwise, there will be high chance of conversion, and you will be doing. There won't be much benefits to the patient, even if you try or even if you are able to do it with a minimally invasive procedure, because you need to select the cases properly in that case. So, feasibility of laparoscopic tumor resection is somewhat limited in most of the reported series, but most literature are also based on lab resection of neuroblastoma in case of abdominal tumors. Another use is use in metastatectomy, especially following pulmonary metastasis to Wilms tumor and all. You can do resection of the pulmonary metastasis using a thoracoscopy. In that case, you use a wedge resection, and also we can do it with the help of linear staplers. And as I said, additional procedures. Example is oophoropexy in case of, if the patient requires radiotherapy in case of pelvic lymph node involvement in lymphomas, and also for second look surgery. Now coming to the technical aspects, a bit about the technical aspects. Always a low pressure pneumoperitoneum is preferred, and basic is the use of endobags. So Ivanaka et al. Had showed experimentally that local or intravenous chemotherapeutic agents such as cyclophosphamide has also reduced the incidence of port-site metastasis of neuroblastoma. In a nutshell, with meticulous selection of the patient, feasibility of lab resection is good, but it needs long-term follow-up data and also proper guidelines has to be developed for the use of minimally invasive surgery. Now we'll discuss regarding individual tumors. Firstly, we'll come to thoracic tumors. So the use of thoracoscopic resection for thoracoscopy is mainly used for resection of mediastinal tumors. So it is mainly used for the posterior mediastinal tumors and also mostly employed for neurogenic tumors. We know that in case of thoracic tumors, mostly the posterior mediastinal tumors are mostly neurogenic tumors, and anterior mediastinal will be lymphomas. And also other entity which commonly appears in thoracic region is the germ cell tumors. So the neurogenic tumors includes neuroblastoma, ganglion neuroblastoma, schwannoma, neurofibroma, and ganglioneuroma. Usually, smaller tumors will be neurogenic tumors will be well encapsulated and easier to deal with minimally invasive surgery, and local infiltration chances will be less. Several studies have demonstrated equally good oncological and surgical outcomes when compared to open surgery. This was a paper which was done by Rothenberg. Then, in case of thoracic teratomas, almost the thoracic teratomas accounts for almost 4% of the germ cell tumors, and mostly they are in anterior mediastinal area. So, complete surgical resection is the most important prognostic factor for malignant germ cell tumors of the thorax. So, it has to be an R0 resection for getting maximum benefit. Another thing is that in case of malignant germ cell tumors, mostly they're present with a local infiltration stage. So you need to assess that thing properly before attempting for a minimally invasive surgery, because the main prognostic factor is an R0 resection. So if you can achieve an R0 resection only, you need to implement minimally invasive surgery for that patient. So as I said earlier, the patient selection is of utmost importance, which determines the success of the surgery. Now, this is a pulmonary metastasis, as you can see on the surface, and this is an image showing the role of thoracoscopy in resection of the pulmonary metastasis. Here you can see a linear stapler, and we are doing a wedge resection of the metastasis from the lung surface. It has got both a diagnostic and a therapeutic role in case of BIMS. You can remove the metastasis, and also you can see for the amount of metastasis, because always we know that whatever lesion is seen in radiological aspect, and when you go intraoperatively, it will be differing. The radiology or the CT won't give you the exact findings of the clear picture. Always when you go in only, you will see the level of metastasis. Now coming to the abdominal tumors, firstly we'll discuss regarding the adrenal tumors. Neuroblastoma is the most common tumor, followed by ganglioneuroma, adrenal adenomas, adrenal carcinomas, and pheochromocytomas. The neurogenic tumors are regularly well confined and not infiltrating or encasing in substantial organs or structures. So this is one fact which is in favor of minimally invasive surgery. So that infiltration part is less in case of neurogenic tumors, and mostly in initial stages there will be smaller tumors, but they will be well confined. The presence of one or more of image defined risk factors on preoperative imaging are considered relative contraindications to minimally invasive surgery. The image defined risk factors are mainly it involves local infiltration, involvement of the mesenteric root, involvement of porta, involvement of the spinal canal, etc. So, and also involvement of the renal pedicles. One or more renal pedicles are all relative contraindications, because this all makes an R0 resection or a proper resection difficult via laparoscopy. And then coming to the role in biopsy, it has also got a role in biopsy also. And various approaches are there for approaching the adrenal tumors. One is I'm just speaking only about the approaches, not going into the details of surgery. One is a retroperitoneal approach, as it is seen in the picture. This is a retroperitoneal approach, and the other one is a lateral transabdominal approach, and also you can go ahead with a supine transabdominal approach also. Coming to the conversion, in all the reported series and all, the conversion rate is only coming till 10 to 15%, and the complete resection happened in almost in 90% of the cases, and complication rate was around 10 to 30%, which was comparable to the open surgeries. Now we have a little word about adrenocortical carcinoma also. Adrenocortical carcinoma, as such, it has poor prognosis. So, inferior oncological outcome after resection with minimal invasive surgery is seen mainly due to relapse of the tumor. So, there is always inferior oncological outcome, even if you use a minimal invasive surgery, and there will be more chance for relapse. It is important to differentiate between the adrenocortical carcinoma and other lesions of the adrenal, because mostly in case of adrenocortical carcinomas, irrespective of mass, which is seen in the radiological investigations, the patient will also have features of hormonal excess. Now, coming to the role of minimally invasive surgery in renal tumors, we'll deal with Wilms tumor. So, Wilms, we know that the main idea or the main oncological principle behind the surgical resection of Wilms tumor is, one is complete surgical resection, and there should be adequate nodal sampling. So, in case of the renal tumor study group showed that the RTSG had shown that there is comparable surgical and oncological outcome with the minimal invasive surgery as in open surgery, but proper RCTs are still yet to come. Most of them are mainly case series and retrospective analysis. So main issue is that with minimal invasive surgery use of MIS is that the discipline, it was seen that the discipline with nodal sampling was not adequate, and also the tumor localization within the organ was also difficult. But now with the advent of endoscopic ultrasounds, this is more feasible. Another issue is, like in most of the reported series, the Wilms tumor, which involves the kidney, it was mostly polar tumors, or which was limited to one pole of the kidney, or which was smaller lesions over the one side of the kidney. So in that case, they tried minimal invasive surgery. So another concern was that if the tumor is limited to one pole of the kidney, always they can go for a nephron sparing surgery. So then it was determined that if it is a polar tumor or a tumor in which you can go ahead with a nephron sparing surgery, minimally invasive surgery shouldn't be tried. Always the first priority should be for a nephron sparing surgery. So it can be done as an open surgery. And if in case a nephron sparing surgery cannot be done, then minimally invasive surgery has a role for the same. And another confusion was that regarding the COG and SIOP guidelines, whether neoadjuvant chemotherapy was given initially or whether a direct resection was attempted. It was found that when the neoadjuvant chemotherapy was given initially and then a resection was tried, better outcomes were there, because surgeons have documented that the chemotherapy helps in formation of a pseudocapsule around the tumor, and it benefits the resection laparoscopically, so that the tumor will not be friable. So the resection will be much more easier when compared to directly going ahead with the surgical resection. Now coming to ovarian tumors, here also a complete resection is mandatory, and also the ovarian preservation is crucial in case of benign lesions. So there is a role for minimal invasive surgery in ovarian tumors also. Another area where MIS has been tried is pancreatic tumors. Here also the case series are less in number, but there is a role for biopsy also. But there is, in case of biopsy, there is always a risk of tumor spillage. And most of the case reports are based on pseudopapillary tumors of the pancreas, but relevant concerns does exist regarding the feasibility of the same in case of pancreatic tumors. A few words about role of MIS in liver tumors also. We all know that in case of adults, minimally invasive surgery has a great role in resection of the liver tumors, and it has reduced the morbidity and mortality also when compared to open resection. And also it is a tedious process, open resection, but now mainly they are turning out towards minimally invasive surgery in adults. But in case of pediatric age group, there are case series which are reported about the use of minimal invasive surgery for liver resection in hepatoblastoma. Sectionectomies, segmentectomies, and even hemihepatectomies have been reported. And also it has got good short-term outcomes and morbidity as reduced. But most of the literature was saying that that were all done by experienced surgeons with above average abilities. So that is another thing, because proper case series or proper RCTs has to come so that we can put proper guidelines for resection of the liver tumors. Another entity in which we can use minimally invasive surgery is sacrococcygeal teratoma. It always depends upon the type or the stage of the teratoma, advanced stage of the teratoma. The pelvic component can be resected via abdomen using minimally invasive surgery rather than going for an open surgery. And then again, you can change the position of the patient, and you can excise the outside component of the tumor. So again, there are case series based on the use of minimally invasive surgery in sacrococcygeal teratoma, and also there are few reports based on use of laparoscopic resection of anterior sacral meningocele also, which is a pelvic tumor with laparoscopy. All these are mainly case reports or case series. No proper RCTs are published till date. Now coming to the summary of use of minimally invasive surgery in pediatric oncology. So you know that the role of minimally invasive surgery in pediatric oncology is evolving, and the protocols of there are various multi-center trial groups, especially the COG groups around the world, which are probably the most promising platforms for integrating such prospective studies in a comprehensive data acquisition and interpretation, and hence leading to the formation of proper guidelines regarding use of minimally invasive surgery. And also a good expertise or good surgical hands are required for getting better outcome regarding use of minimal invasive surgery. There's always a learning curve issue there, but if there's good expertise, the outcome can be better. And long-term follow-up has also to be reported, because most of the long-term outcomes we don't know. So there has to be long-term follow-up of such patients to determine the exact use of minimally invasive surgery in pediatric oncology. Thank you.
Yeah, thank you, Sethu.
Yes.
That was a very comprehensive discussion of a very controversial topic of use of minimal invasive surgery in laparoscopy, in solid organ tumors in children especially. As for regards to your neuroblastoma, any specific indication other than IDRFs about the size or something, or including pheochrocytoma, anything you know of?
The size 5 centimeter cutoff.
Yeah, some. Yeah, most series report that 5 to 6,
5
including
centimeter.
Yeah.
Then in some this thing in Wilms also they mentioned when you're seeing on the image the tumor shouldn't cross the vertebral margin.
Yes, tumor shouldn't cross the vertebral margin. Volume less than 500 ml of the 500 grams of that.
Yes.
That would be there. Yes. Yeah. Thank you, Sethu. I think I'll open it up for any questions or discussion from the other participants.
Yes.
Sethu, at the outside, I would like to congratulate you. You did a wonderful job. In fact, you highlighted almost everything that I actually wanted to talk. At each level, you conveyed the advantages as well as the concerns. In fact, the concerns is one which, despite us being the pioneer in laparoscopic surgery, we are still not able to do too much, because of the same thing that we don't want to violate oncological principles. All right. So our experience is also not too great, because we don't want to experiment too much, like Gowrishankar said. We have, in fact, he wrote a chapter recently on role of minimal invasive surgery. That's why I gave him the moderation part of it. You did a brilliant job. Okay, one thing I would like to highlight is, last year I had gone to Europe for one of the STEPS meeting, that is strategies and trends in European pediatric surgery, which was exclusively focused on pediatric oncology. One of the topics was about Wilms tumor. In fact, I was talking about bilateral and difficult Wilms tumor, and others were also talking about role of minimal invasive surgery in advanced surgery. In fact, most of the centers in Europe, now actually are now comparing between role of laparoscopy versus nephron sparing surgery. As
Yes, sir.
rightly said, the patients where the success of laparoscopic surgery in Wilms tumor have always been small tumors, polar tumors without much spread after neoadjuvant chemotherapy. In fact, the consensus was all these cases actually are highly suitable for nephron sparing surgery than just laparoscopy. So
Yes,
when you
sir.
compare for a child, more than the scars, having more renal tissue is far better. So the
Yes, sir.
general consensus was if a case actually comes down for Wilms tumor, which actually is suitable for laparoscopy, maybe a nephron sparing surgery should be offered in the interest of the child. I completely agree.
Yes, sir.
Because in all our experience, I think we've done only one case of Wilms tumor because simple reason. Emotionally, a child with stage 1 Wilms tumor has got more than 95% survival rate. The moment if there's a spillage,
Still,
it
it
comes to stage
requires
3,
radiation.
survival rate drops.
Yes,
Some of them not been able to reconcile to the fact. So that's perhaps the reason why we've been waiting for more research. As I told, more than laparoscopy, maybe nephron sparing surgery in Wilms tumor is what will come. As far as we are concerned, we have used laparoscopy mainly for diagnostic purposes, resection of thoracic tumors, resection of residual tumors, adrenal tumors is what generally are, maybe ovarian tumors, where it is more benign than malignant. Whenever we think it is a ovarian tumor can be cancer, we have always been hesitant. Same thing about adrenal carcinoma. If we think it is adrenal adenoma, we go in. If it is adrenal carcinoma, or even if there is a suspicion at the surgery itself, because it's very friable, we do not hesitate, we convert it immediately. I'm sorry, I've given everything. Jyoti, Ramchandra sir, and others.
Yeah, sorry, but if I could just concise the thing. As of now, the available literature says the present for mainly adrenal tumors, yes, it's a very good standard of care, especially small sized and no presence of IDRF, as you mentioned, involving the encasing the vessels and things like that. And pheochromocytoma again, less than 5 centimeter, which has been handled very adequately by laparoscopy. That is definitely there. And as you said, you very well put it. That's a discussion going on for Wilms tumor now, to migrating towards NSS, and surprisingly, there has been no integration of laparoscopy into any of the trials. So now, only initially it started in 94, but 2004, but it was given up for certain reasons. That was with the COG group, but since then it has not been incorporated to any of the trials. So as of present, this thing there is adrenal cortical carcinoma is not indicated. You have to be very clear. You should not do for that. Second one is ovarian malignant tumors, epithelial tumors. Definitely, it's not an indication for laparoscopy because where there is it can be a aid in staging, as in assessment of the abdominal cavity, diaphragm, liver surface, and such things. But procedure would be open, and other neuroblastoma where there is involvement of or presence of the risk factors, radiological risk factors. Rest of it, it's evolving field. I think, as Sethu has put it, you have mentioned, we should take concern, utmost concern. Also, the most of the things, one major thing which has been highlighted is those who are doing this are mainly laparoscopic surgeons, not oncology surgeon. So that is one thing which is highlighted in most of the series. So probably they have to, that concern also exists. And with this, I think is otherwise he is very well conscientious. Thank you, sir.
Yeah,
Thank you.
Sethu, you have done a good job of presenting very
Thank you,
concisely
sir.
and nicely.
Yes, sir.
One thing which I wanted you to highlight was the emerging branch of robotic
Robotics.
minimally invasive surgery in pediatric oncology.
Yes,
There
sir.
are some meta-analysis and systemic reviews appearing in the literature where they point out to the superior benefits of superior use of robotic surgery for pediatric solid tumors. There are not many numbers. That's why they have done systemic review and meta-analysis. So they are
Yes.
telling it is a definite advantage over conventional minimally invasive surgery. And I think it can be, as Dr. Ramesh was pointing out, in nephron sparing surgery, there may be a role for robotic surgery when you're planning to do a partial nephrectomy. I think that's a excellent application of robotic surgery doing a partial because the amount of the fine dissection which you can do with the robotic instruments is something which you have to watch and realize. the same thing with the Wilms tumor in horseshoe kidney. I think it is eminently, resectable through robotic procedures. And for some pelvic tumors, when you want to do a pelvic lymphadenectomy and all, it gives excellent exposure and good magnification and very good handling of the tissues and fine, precise dissection. So I think robotic surgery will come in, but it may take another generation, half a generation before it will be routinely applied. So that's what I feel. Okay.
Yes.
Thank you very much, sir.
Good job.
Very, very valid point. In fact, as you rightly put, robotic surgery has sort of overtaken laparoscopy. And this is one particular instance where I feel robotic is more applicable than laparoscopy. In fact, the role of laparoscopy is slowly dwindling in MIS. In fact, every time they've been calling me for talks across, I've been giving the same idea. I've been conveying the same spirit that unless oncologic principles are adhered to, laparoscopy should not be attempted. Jyoti, any questions? I see Jyoti and Pooja.
Sir, there were two other points which I thought of were of interest. One is the role of minimally invasive surgery in fertility preservation, especially in ovarian tumors.
Lovely.
All the ovarian transposition typically is done under laparoscopic technique. The second thing is lung metastasis. There are two scenarios here. One, lung metastasis, where only laparoscopy is used for a diagnostic procedure, such as in Wilms tumor. We don't usually require resection of Wilms tumor nodules because they respond to chemotherapy. Whereas in tumors, in bone tumors, resection of the nodules is required. So MIS is typically indicated in diagnosis of pulmonary nodules and Wilms tumor, whereas in bone tumors, MIS is contraindicated because though on CT scan we may pick up certain nodules, apparently when they go in during the surgery and they manually palpate the opposite lung or the same lung, the deeper tissues of the same lung, clinically several nodules will be picked up. This is a known phenomena. So the CT finding of the number of nodules is usually deceptive. Clinically, they tend to pick up more nodules than what is visible on the CT scan. So therefore, MIS is contraindicated for resection of nodules, lung nodules and bone tumors, whereas it is indicated for diagnosis of lung nodules in Wilms tumor.
Jyoti,
hello, sir. So, as actually Sethu did mention about the ovarian additional use of laparoscopy earlier in his talk. That was that ovarian preservation.
Okay, sir. Okay,
And also other role is when they are using for azygous vein cannulation, especially when you don't have IV lines, they use for chemotherapy. So again, thoracoscopy is another role where it has for azygous vein cannulation and for catheterization. And as you rightly said, yes, especially there is controversy regarding use of metastaectomy for osteosarcoma, especially very specifically for osteosarcoma. There are papers which say yes, it can be done, but as you said in CT scan, it shows solitary lesions, but when you palpate it, there are multiple lesions. So as of now, it is very controversial or not indicated for doing metastaectomy in children having osteosarcoma metastasis in lung. Yes, very true.
Okay.
Sir, the meeting will end in 5 minutes. I will restart the meeting.
No problem. We'll finish the discussion by that time. No problem. Jyoti, just
Yes,
to add a thing, the place where we have actually done a pulmonary metastaectomy was a child with Wilms tumor, treated primary, secondary, cleared. And then he presented with an isolated metastasis which was not responding. And
that is chemo unresponsive. Yes, sir. I was talking about upfront metastatic disease. Usually the Mets respond to chemotherapy, and if they don't, we have to. Yes, sir. Correct.
This is the only instance where we have done it.
Okay, sir.
Number two, for the ovarian transposition, it's all good. But actually, in practical application, I've seldom seen it. Is it necessary that often? Because in all my experience, I've never got a request for it or never done it.
Maybe it is to do with the sensitization of the referring pediatric oncologists, because it's an emerging field. We are frequently asked about fertility preservation, but we don't do it because the pediatric oncologists themselves are not sensitized enough to the need.
Okay. Maybe only if you're going to be doing a radiotherapy, right?
Yes, sir. Yes, absolutely. It is only to prevent radiation-associated ovarian failure.
And also, basically,
I thought the necessity for radiotherapy in lymphoma in pediatrics is not that much. Not very frequent.
Yeah, exactly. Sir. So it's mainly in the adult age group and also the sensitivity of the ovary to the radiotherapy. That's what they've noticed during the pubertal age group. So probably in the older age group, yes, there it's a very common procedure that is followed because in our this thing, we have not done the as of now.
Sir, it is not precisely for ovarian tumors. It is for any pelvic tumor that will require pelvic irradiation. That ovarian transposition is recommended. Transposition is recommended.
I
It
was
need not be
referring to
for an ovarian
lymphomas.
tumor. It can be for any pelvic tumor. It is about that pelvic Ewing sarcoma, rhabdomyosarcoma in the pelvis. These are the type of tumors which we more
I got
commonly
it,
see.
Jyoti. I got the
Yes.
point, but unfortunately or fortunately, we never got such cases. That's all I was. No.
Yes, sir. Maybe henceforth.
No, but it's very, very valid for us to be sensitive about it.
Yes, sir.
If it is needed, yes, we will rise to the occasion.
Sure,
Okay.
sir.